to figure out how this is working for the sound. I think we gotta ask them to move that basically. If they could put it over there, that'd be nice. Yeah. If you ask. If we ask. You're coming now.
You enjoy the workshop? Pretty good.
What?
This is Regina Bavaraju from the RTMCC. We'll be started momentarily. Does anybody have any problems that we need to deal with before we get started? Okay, then I'm going to ask you all to put your phones to mute, and I'm going to turn the call over to Bill Bauer, who will be hosting today's program. Bill?
Good morning. Welcome to the Educational Conference on Working with Patients with Mental Health Issues. My name is Bill Bauer, and I'm Director of Education and Training at the Charles P. Shelton National Tuberculosis Center, which is affiliated with the Northeastern Regional Training and Medical Consultation Consortium at the New Jersey Medical School. Today's program is co-sponsored by these two centers. Could I have first, please, a roll call of participants? Carmen Pretty, are you there? No? Kathy Goldsboro? Oh, they're on mute. Excuse me, I guess if you were all muted, it would be hard for me to know if you were there, but we will look on our panel here and see everyone who has attended. So we can skip this step. Before we begin, I would like to ask that if there are any sites with multiple persons on the line, that participants sign in on a sign-up list there, or the sign-in sheet, which has been provided. The UMDNJ Center for Continuing and Outreach Education certifies that this continuing education activity meets the criteria for continuing education units, or CEUs, as defined by the National Task Force on the Continuing Education Unit. One CEU is awarded for 10 contract hours. Anyone who would like to receive CEUs for this activity must also complete the CEU information sheet. Please note that there is a $10 processing fee for receipt of CEUs, which must be received within a week of this conference. In addition, we ask that each person listening today complete an evaluation form. This will ensure that we receive feedback about today's program and enhance future educational offerings. Now, you have all received the slides ahead of time. We emailed these on Friday, and you may use these as printed handouts or view them on your personal computer. We ask that you follow along closely, and we will try to be as clear as possible when transitioning from one slide to the next. Many of you are joining us via WebEx today, the WebEx site, and you will see the presenter move to the appropriate slide automatically. Finally, I would like to inform you that today's program is being recorded for future listening and will be available on our website at www.umdnj.edu/globaltv. The format of today's conference will consist of a presentation in several parts by Paul Colson. There will be case studies following several of the parts. The objective are that by the end of this session, you will be able to discuss how mental health issues impact completion of treatment and contact investigations, describe 3 common mental health problems, list the signs and symptoms of these disorders, discuss what treatments are available, outline techniques for handling these issues in the clinic or field setting, and recognize when to refer patients to mental health services. We will switch your phones to mute to eliminate any background noises, and each presentation will be followed by a period for the case study and questions and answers. On the WebEx site, on the right of your computer screen, you should see icons with options for raising your hand to indicate when you have a question. However, if you feel more comfortable just speaking up when you have a question or comment, please do so. You can get our attention and we can open up your phone for speaking. There's also a chat box for questions if you wish to type your questions in, and we will keep track of that as well as the time to make sure that we cover the content and allow people to participate. Today's presenter is Paul Colson, PhD. Dr. Colson is the program director of the Charles C. Felton National Tuberculosis Center. He has 22 years' experience as a researcher and manager involved in programs serving clients with multiple problems, including mental illness, homelessness, tuberculosis, and HIV/AIDS. In fact, before working in tuberculosis, Paul worked with homeless people with mental illness in Chicago and New York. Now I'll turn the program over to Paul. Paul?
Thank you, Bill. I just turned to the first slide of my presentation that says prevalence at the top. 22% of Americans ages 18 and older suffer from a diagnosable mental disorder each year. Major depression affects approximately 5% of the adult population in a given year. These are just a couple statistics. I could probably throw a lot more statistics at you about prevalence and incidence of mental disorders. I think the important point is that persons with mental illness may be a small proportion of our patient population, but they can take a lot of our energy and time. You should be aware that people with mental illness may be diagnosed and their illness under control, or they may have been diagnosed but are not taking their medications, or the medications aren't working properly, or they could not be diagnosed with the disorder that they suffer from. Or also a final possibility might be that mental illness in various forms could be triggered by the stress of having TB or HIV or another illness. The point I'm trying to make about this is mental illness is not confined to a small group. Many people experience it, learn to cope with it, or not, move in and out of periods of greater and lesser disability. Now, how do mental disorders impact the completion of treatment and contact investigation? In other words, our work in tuberculosis. Moving to the next slide. First, I'd like to discuss depression. What is depression? Well, depression is more than just having the blues or the blahs, more than your normal, everyday ups and downs. Clinical depression lasts more than a couple weeks. It's not the sort of bad period you go through for a couple weeks. In addition to feelings, depression can change one's behavior, physical health and appearance, your academic or job performance, your social activity, your ability to handle everyday decisions and pressures. What causes depression? There's no definitive answer to that question. It seems to be a mixture of biological and emotional factors, which may include a genetic link. The chances of being depressed can result from having difficult life experiences and your personal patterns, such as difficulty handling stress, having low self-esteem, being extremely pessimistic about the future. However, I do want to stress that depression doesn't simply come from bad life experiences. If that were the case, then probably large parts of the developing world would be depressed, and we in the developed world here would be happy as clams. But we know that's not the case. So depression is not linked exactly to what's going on in your life. Moving to the next slide, there's three major types of depression. The extent and length of illness may vary in these. And again, depression can range from a general feeling of hopelessness and low energy to really an incapacitating illness. First type of depression is major depression, which has a combination of symptoms that we'll look at in the next slide. Symptoms that interfere with the ability to work, study, sleep, eat, and enjoy pleasurable activities. Disabling episodes may occur only once, or more likely several times in one's lifetime. Dysthymia is another type of depression. Dysthymia includes long-term chronic symptoms which are not disabling. They keep one from feeling or functioning well. with schizophrenia may also experience a major episode at one time in their life. There's some sort of background music. I'll continue. The third type is bipolar disorder, which has also been referred to as manic depressive illness. In bipolar disorder, there are cycling mood changes, ranging from mania to depression. These changes may be gradual or they may be abrupt. And in some cases, if untreated, the mania can lead to a psychotic state. Now here's a list of the symptoms of depression. It goes on 2 slides. Being persistently sad, anxious, or having an empty mood, and feelings of hopelessness or pessimism, feelings of guilt, worthlessness, or helplessness, loss of interest or pleasure in hobbies or activities that were once enjoyed, including sex, decreased energy, fatigue, being slowed down. That's something that people with depression often identify that feeling, being slowed down, having difficulty concentrating, remembering, making decisions. Moving to the next slide, having insomnia, early morning awakening or oversleeping, appetite and or weight loss, or overeating or weight gain, thoughts of death or suicide with suicide attempts, restlessness, irritability, and persistent physical symptoms that do not respond to treatment, such as headaches, digestive disorders, and chronic pain. Moving to the next slide, symptoms of mania, abnormal or excessive elation, unusual irritability, increased need for sleep, grandiose notions, increased talking, racing thoughts, increased sexual desire, markedly increased energy, poor judgment, and inappropriate social behavior. Moving to the next slide, depression and grief. Sometimes depression is confused with bereavement or grief. They have similar symptoms. However, what are the differences? Bereavement can be tied to a specific event, usually a death of a loved one. Bereavement is self-limiting. That means with support and time, eventually a person will adapt to the loss. While in contrast, depression needs an intervention. Depression will not go away on its own. Now certainly some people live with depression without getting help. And depending on how severe their illness is, that may prove successful in the short term or even the long term. But a clinical depression, again, really needs an intervention. In bereavement, by contrast, the major treatment, if you want to call it that, is working through your feelings toward the person who died, readjusting to life without that person, forming new relationships. There's not generally a need for medication when a person is going through a bereavement process. In depression, there generally is. So moving to the next slide, treatment for depression. There's a variety of medications available at this time, and there's also psychotherapy, which has been available for a long time. In mild cases of depression, sometimes the talk therapy, the psychotherapy, is sufficient. There's some myths I'd like to address about depression. Sometimes people say, well, he just needs to get it together. He just needs to pull together. What's wrong about that is it doesn't acknowledge the seriousness of the disease. Depression is not a weakness of character. It is a health disorder that requires treatment. Some people say, oh, just talking about it makes it worse. You just got to, get into this cycle of being depressed and talking about it. In contrast, talking can help a person, for one thing, help other people recognize that a person needs help, to encourage them to get help for their depression. But talking for the person who is depressed can help them reach out to others and get support, and they can build trust with others and receive that support. The The next slide, depression and substance abuse. Depression is less likely to lead to substance abuse directly, in contrast to people with schizophrenia, where often the illness itself leads people to try street drugs and things in a way to try to self-medicate. That's a bit less likely in depression, but there certainly is an association between substance abuse and depression. Often substance abuse might predate the depression, and it works sort of like in a downward spiral, where the more depressed the person becomes, they might use substances more and become more depressed. So it's certainly excessive drinking and drug taking can reinforce depression, and it's something that needs to be addressed also when a person enters treatment. Now I'd like to focus on case study A, and I will read through the case study and then pose several questions, and I'd like people to join in and share your thoughts at that point. Mr. H is a Latino man in his 20s living in the city. He is being treated for MDR-TB. Mr. H has completed 1 year of treatment, has been generally adherent. However, recently, his mood seems different. Mr. H tells you he doesn't like taking the medications. When he comes to the clinic, he often appears disheveled with poor hygiene. Mr. H says that he is not eating regularly. So, Regina, if you could unmute everyone, I'd like to pose some questions and we can discuss this. What are the factors to consider in working with Mr. H?
We can hear you now, so you can respond about any of the factors that you think are important in working with Mr. H.
So he's showing symptoms of depression, and so that may mean that in order for him to continue successful TB treatment, he may need to be encouraged to be evaluated for whether he needs mental health treatment too.
Those are good ideas. Does anyone have anything to add about what you would think about?
How about homelessness?
Well, the case he didn't say he was homeless. Are you concerned that that might happen as a result of...
That may be the cause for the disheveled appearance. It could be something to consider as a factor.
Yeah, you're saying that maybe the reason he's disheveled now is, without your knowledge, he's become homeless?
Absolutely.
I think you would need to talk to him and find out exactly, or with the physicians treating, as to how long his ongoing treatment for TB needs to go. I mean, he's completed 1 year, and certainly, that could get him down as to how much longer he's going to have to go for treatment for this disease.
So he has been in treatment for 1 year.
Correct.
Right.
But he's got MDR, so it would have to be determined how long the treatment would have to go on. And if somebody could, give him encouragement as, this will end in another year or 6 months, or if we could find out how much longer the treatment needs to go.
These are good ideas. Let's look at the second question. How would you work with Mr. H? Any ideas on how you might approach the situation?
I think, Francisco, we see that you had your hand up. Did you have something you wanted to contribute? Francisca?
We kind of missed the first part of the training, and we wasn't exactly sure what MDR-TB was. Is it TB coupled with something else?
It's multi-drug resistant TB, in which case the treatment is usually
much
longer and more medication.
Okay, thank you.
Continue to call for appropriate counselors and speak Spanish to discuss other issues that are
are happening back in his home country.
Okay. That's a good point. They need to consider language or cultural issues here.
And also, could some of these symptoms be a side effect of the medications? I certainly want him reevaluated to see if any of it could be side effects of some of the medications.
Okay.
I think first also you need to get a little bit more information because it says here that his mood is different and that he's telling you he doesn't like taking the medication. So I guess if I were working with him, I would explore that a little bit with him and try to find out what's going on and maybe have some more information and then make a decision about how to proceed.
Mm-hmm.
And also focus on what has changed when he first started taking the medication that makes him a little more resistant after a year of treatment.
What do you think about the fact that he's already been in treatment for a year?
Well, if he's been in treatment successfully for a year, I would assume he has a relationship with whoever is working with him if he's doing daily observed therapy. And so the question of whether there's been any change in his circumstances, I think, would hopefully be obvious to whoever's working with him if he's getting cared for a whole year. But something has changed in his life, and I think it's important to get to the bottom of what that is. It could be circumstances, and it also could be simply mental health issues that were not either as prominent or weren't present a year ago or during the course of the last year.
That's a good point. That's the point I wanted to make was the fact that he's been in treatment for a year. On one hand, you could say he's getting tired of it. He says he doesn't like the medicine anymore. On the other hand, the fact he's been in treatment for a year suggests that he has a relationship built up with one or more workers that would provide an opening to maybe leading into something that he may be uncomfortable with. This is the idea of getting mental health treatment. Many of our clients have stereotypical view about, head shrinkers or, those sort of, pejorative terms about getting mental health.
Many of us do, you mean?
So there may be some resistance when you approach these issues with Mr. H. The third question, how do you think Mr. H's condition affects his adherence?
Well, the depression condition could make him unwilling to take his medicine, trying to just being negative about lots of things in his life. This could be one more thing. That he just, or maybe this is the only thing in his life that he feels he has any control over, which is to tell the TV worker that he doesn't want to take the medicine anymore.
Mm-hmm. Good point. Others have ideas about this? About his adherence?
Perhaps someone should talk to Mr. H about his history, because this may not be his first episode of depression. He may have been going through this for some time on and off, and maybe there is a certain type of care that he receives when he's depressed.
Good point. Yeah, I think, you're all making the point, too, that one would want to be cautious about his adherence from this point on. It appears that he's been fairly adherent for this year of treatment up to this point, but some things are changing, and we're not sure what those are. We're suspecting depression. I think someone said that just a change in life circumstances may be leading to some of these, what we were considering symptoms, being disheveled, having a poor appetite, poor hygiene, maybe simply because he's lost his housing and is staying in a shelter or something. So there's a number of things to explore. I think we all agree that some action does need to be taken, though, in advance of either his dropping out of treatment or otherwise being poorly adherent.
Very good. We'll move on now to the next part of the presentation, and forgive us, but we will be putting your phones back on mute to eliminate the background noises.
Are there any questions before we do that? Oops. I don't know if you already did that from Virginia. Is the mic still open? Any other questions about the first section? No, everyone's on mute, so there's no questions, so we'll move on. There will be other times, of course, when the phones will be on again. Okay, the next section, we're moving to the next slide, it's just titled Suicide. Now you may be wondering, why are we talking about suicide? Suicide is probably less of a threat in TB control than it is, for instance, for people working with patients with HIV or AIDS. However, many of our patients are co-infected with HIV and TB. And because of misinformation or experiences that people have had in other countries, some may overreact to getting the diagnosis of tuberculosis. Also, I would say in healthcare settings, we have a special obligation to be careful about suicide, to try to prevent it, and to get help for people who may be considering it. The next slide lists risk factors for suicide. And as it states at the top, it's important to note that many people experience one or more of these risk factors and are not suicidal. So it's not obviously a cookbook approach that if these things are happening, then you'll be suicidal. Not at all. Such risk factors include one or more diagnosable mental or substance abuse disorders, having a family history of mental or substance abuse disorders, suicide, violence, including physical or sexual abuse, incarceration, adverse life events, exposure to the suicidal behavior of others, including family, peers, or in the news or fiction stories, impulsivity, a prior suicide attempt, and having a firearm in the home. Now, what causes suicide? Depression and substance use are often present. It's difficult to predict suicide, though. Again, having these sort of risk factors doesn't suggest a causal relationship that suicide will necessarily be a risk when these things are present. But if one has many of these risk factors, you certainly should be concerned. Who is at risk for suicide? There's a misconception that suicide is most common in young people. And certainly there has been dramatic cases of young people committing suicide, or even in sort of like a contagion pattern where in a given town or area, a number of youth may commit suicide, either together or sequentially. But in fact, the demographic group that is at highest risk for successful suicide is elderly white males. Now, why might that be? One reason might be that elderly white males are more deliberate in their attempts. They're more likely to use firearms than other means. They're less likely to reach out to others when they have problems and talk about either their dissatisfaction or their plans for suicide. And they may be less likely to recuperate from depression or other problems because of their age. What impact does substance use have on suicide? Well, lower-age drinking laws have been found to increase suicide among youth. Suicidal ideation is higher among depressed people. And people who use substances often have other risk factors, whether it be financial problems, impulsivity, factors like that. Turning to the next slide, this list is titled Assessing Risk of Suicide. This list is what a social worker or other mental health professional thinks about when assessing a person's risk for suicide. 1. When did she last have a thought about killing herself? 2. How often does she think about killing herself? 3. How comforting do these thoughts seem to her? 4. Has she made a previous suicide attempt? 5. Does she now have a plan to kill herself? And 6, can she carry out the plan? Now, what you should think about in our work in TB control is really the answers to questions 5 and 6. These are not questions you should ask outright. You shouldn't say, do you have a plan for killing yourself? But rather open-ended questions to get at what they're thinking about. You know, what are you thinking about now, or why do you say that? Can be good responses to try to elicit more information from the patient. But the information containing the answers to 5 and 6 are the most important to think about. Does the person have a realistic plan for killing him or herself? And if it does seem like they do, that's the point at which you need to get them to a mental health professional, whether that be in a psychiatric emergency room or a hotline. Samaritans run a hotline for suicide risk, or just a general emergency room. Move to the next slide. Like with depression, there are myths surrounding suicide. One of them is, those who talk about it don't do it. Well, that's not found to be the case. There are many successful suicides who have first talked about, who have let their unhappiness be known, and unfortunately that has not been responded to in a positive way, and then they've gone ahead and successfully committed suicide. Some people say, well, if you talk about suicide with a patient, it may put the idea into their mind. I can tell you, I don't think there's anybody who hasn't heard the word suicide, who if they're unhappy, hasn't at least given some thought to suicide. Raising it with a patient, trying to get them to verbalize their feelings, and possibly using that word doesn't mean you're going to suddenly decide, oh, here's an option I didn't think of. They can certainly think of that option on their own. Another myth is the idea that most people don't want to commit suicide, so if you challenge them to do it, they'll back down. Now, I don't watch a lot of TV, but it seems like often what I do, particularly like in cop shows, this sort of scenario comes out where someone is threatening suicide and the cop will say, well, here's a gun, you know, you just go ahead and do it. Just sort of challenge them to do it. That's a bad idea. There's actually a form of treatment called paradoxical treatment where you do challenge a person on what they're stating. It's not a good idea to try to use that technique in a suicide situation. There's a good chance that the person will either take you up on it or some sort of harm will occur that you wouldn't want to have happen. So what to do in a case where you think that your patient might have suicidal thoughts or plans? First thing is to listen non-judgmentally, not to leap to conclusions about, you know, calling police or other people. First, listen carefully and determine whether you need to try to get them to a professional. Again, a ER, psychiatry department, social work, etc. If it does seem there's a possibility of a realistic plan in place, you should not leave the patient alone. And if there are any firearms or other means of harm, you should remove those. If you can't remove them, then removing the person, getting the person to leave and go somewhere else. And again, not leaving them alone. What's important is to know your program's policy regarding the procedures to follow when there's suicidal ideation or intent expressed, or if there's homicidal intent. There was a court decision some years back called the Tarasoff decision, where a psychiatrist was held responsible when his patient said in a therapy session that he was planning to kill his fiancée, and then went out and did it. And the psychiatrist did not warn the fiancée or the police. So if you get information from a patient that they're intending to harm someone and you do not act on it, you are liable. Now I'd like us to look at case study B. Let me read it first, and then again we'll discuss it. Miss B is an Asian woman in her 30s living in your town. She was named as a contact of someone with pulmonary TB. 2 days ago, you educated her about TB and administered a skin test. When you visit her to read the skin test, Miss B is very agitated. much of what she says doesn't make sense. You note that there's a large knife on the coffee table. Okay, and Lucia, if you could unmute everyone. And let's talk a little bit about this case. What are your immediate concerns?
It's a language problem.
Uh-huh. So the fact of what she says doesn't make sense, you are attributing maybe it's just a language difference.
Correct. I think you would need to have an interpreter that speaks her language to make sure that she understands exactly what you're trying to relate to her and explain the facts of this positive skin test and what it means and the treatment that would be available to her.
Okay. Others? What concerns would you have?
Well, we don't know that the skin test is positive from this case study. So we have to assume that she is agitated either in anticipation of the results or perhaps because she may be aware of what the contact is. So the immediate concern is to be clear on why she's agitated. And that would require good language skills. And the other problem here is that we probably don't have a relationship with her. This is just a contact investigation. So beginning a relationship and trying to understand why she's agitated would be the first challenge, I think.
We also don't know if she's, when you say much of what she says doesn't make sense, is that because she's speaking incoherently, which would be a concern if she's agitated and speaking incoherently, or is it because we just don't understand her accent or her language? So if she was speaking incoherently, agitated, and has a large knife on the table, I mean, those are all obviously red flags.
Let's take as a given for a moment that the fact that she's Asian doesn't necessarily mean she came from another country. She could have been Asian and born here and speak English as well as you and I. Maybe I don't speak so well, but we're thinking in that situation. So the fact that she doesn't make sense isn't due to an accent or poor command of English. Any ideas about, so let's think also about the second question here. Would you say something about the knife on the table?
Yes.
And if you would, sort of how would you introduce that?
Perhaps I would ask if I interrupt her preparing a meal or something because the knife is on the table. Exactly what was she doing before I got there?
Mm-hmm.
And if that doesn't give me an answer, and then I may be very direct and ask her about the knife on the table.
Mm-hmm. Now, would some of you think that maybe I don't want to ask about it because it might inflame her or, you know?
Well, I think it would if you could determine why she's agitated, it would make a big difference in whether how much you bring up the knife or any other kind of visuals or concerns about the environment that she's in at that particular moment. If we're assuming she's agitated because we're doing a suicide thing, then we would definitely not walk out without being clear on a knife on the table. But if I were walking in on a patient that was agitated, I'd want to find out why she was agitated.
I think if I went in someone's home and it was clear that they were agitated and I couldn't understand what they were saying because they were speaking incoherently, I might assume they were having some kind of psychotic episode and make my decisions from there, especially if there was a knife on the table and she was clearly agitated. It seems like it could potentially be a bad situation.
Mm-hmm. So you might be concerned about your safety in addition to the client's safety.
Well, yes, because it would be hard to assess what's going on if she's speaking incoherently. I might not be able to say to her, you seem agitated, can you tell me what's going on? if she's speaking incoherently, then I'd be concerned about my ability to assess the situation, from her narrative.
So, the next question. Ms. B's skin test result was positive. How would you discuss this with her?
Is this patient still agitated?
Let's say for a minute that she calms down a little bit.
I think it's a bad time to just make, based on the scenario, somebody who's agitated, speaking incoherently, obviously having something going on with them outside of perhaps this issue of a skin test. I think you need to establish some safety for her initially, and I don't think anything you're saying to her would possibly get to her, or actually understand or be able to absorb any of the information you're telling her or offering her if she's in an agitated state. That's not a good time to be talking to somebody and giving them good information. Because no matter how clear you are, if she's not clear and not able to accept that, she's not going to get that information.
Right. So you're suggesting it's not a good time to talk about this. You should probably leave.
Not necessarily, but I think if I was unsafe or I came into a household like that and I've done home health and I felt that unsafe, I would certainly get some other help for her, and I wouldn't leave her.
Okay.
So I, figure out, even approach it. I'm uncomfortable with this situation. I'm concerned about you. Is there anybody else at home today, or if you don't know this person, perhaps you know the contact, or maybe it's a household contact. Maybe you can access your patient and get some information, or get somebody to be with her while you get some help for her, or maybe elicit the help of somebody in her family to be with you when you're talking to her about her skin test. I wouldn't ignore it, but you certainly, what is the point of talking to somebody who's agitated, or, you're really not going to get very much from it.
Okay. Well, you made the point that you wouldn't try to give her health information at that point. Now, she does, since her skin test was positive, she does need to be medically evaluated, LCBI treatment.
Right.
How would you deal with that? And would you alert the clinic to what you found in this home visit?
You might ask her to come into the clinic. I'd like you to come in and we can talk about this. Or ask her to, ask the patient to bring her into the clinic, or be there with her if somebody else is with her. She's all by herself. I certainly wouldn't want to offer that information, which may be the precipitating issue for the anxiety or the, episode that to tell her information and leave her. That's not very effective, and it may further agitate her or push her towards, acting out on some, input. It's certainly important to evaluate her, but the emergency is more dealing with her. If you come upon somebody who's that agitated or not incoherent, you certainly don't want to, add to what may be going on with them internally. You don't know how she's interpreting anything you're doing. So you want to make sure she's safe first, and maybe the safest place would be to ask her to come into the clinic.
Right. Good point.
Or call 911 if you're that afraid, and to get her evaluated. Bring her into the emergency room and then do your evaluation while there's somebody there that can help her and further evaluate her.
Good. Okay. The last question is, how might her behavior affect her adherence to LCBI treatment?
Well, if she remains in this state for a period of time, I would think that she's not going to be very compliant at all with her LTBI treatment. But I wanted to just say something before we moved on to this question. I would actually be more concerned about her mental state than her LTBI at this point, and probably, depending on how agitated she is, I probably would actually call the clinic and speak to a doctor and tell a doctor or a nurse or someone exactly what's going on. And I probably would want to have her to go into a hospital. And if there's someone in the household, I probably would ask them, how long have she been agitated or upset? How long has this been going on? And do you know what triggered it? And if there's no one in the home, then I would probably speak with the doctor about it and probably opt to take her to the emergency room.
That's an interesting point. I mean, we all work in TV, so we're sort of thinking that's our priority, but what you're suggesting is her behavior, which may have a risk of suicide, may be the more important thing at this moment in time. Now, we do have to remember she tested positive on skin test. She could have active disease. We don't know that.
Exactly.
So if she had active disease, I think you're suggesting, I would agree with us, that dealing with the current situation is probably more important at this point in time than her tuberculosis treatment.
I actually had a patient who was like this, and she was known to be HIV positive and end-stage AIDS, and she was going through dementia. And she actually had been in this state, although she wasn't violent or agitated. She was just incoherent, and she was in a facility where she was supposed to be drug and alcohol free, and they thought that she was actually using drugs again. And when she actually went to the hospital, it was diagnosed that she was actually going through this dementia, that it had nothing to do with drugs at this point.
So her symptoms looked similar to a person using drugs, but hers was caused by the dementia.
Right, exactly. Toxoplasmosis, I believe.
Okay.
I think her mental, I agree with the woman who spoke earlier that her mental health status is more important, because in order for her to remain adherent to the LTBI treatment, she needs to be mentally stable.
Right. Good. Are there other comments people want to make about this case study or questions about suicide and suicide risk?
It's really no different than coming upon a patient. We have patients who have other underlying medical problems. We've had elderly patients or even young patients who had underlying other pulmonary issues or heart issues, hypertension or COPD or whatever, and they may be being evaluated by other clinicians for those issues. And if you come upon a patient who's medically unstable, TB goes out the door, or an evaluation goes out the door. You're triaging, you're doing what you have to do first. And, those people that, nurses that go out in the field and do that, that's what you do. You never forget that. You go in, and if your patient's on the floor, the fact that they have a positive PPD really doesn't matter. You're going to get them evaluated. So I think you should look at it in those terms. That's the most important thing.
Another comment is we had a patient in Anne Arundel County that overdosed on Orion. She was given, it was a Hispanic teenager in high school, was given her first bottle and got upset with her sister, went in the bathroom, and that's all she could find, and she took the entire bottle and ended up with seizures.
Okay, I'd like to move us to the third section of today's talk. So we can advance to the next slide, which is schizophrenia. So schizophrenia is the worst of the mental disorders. People with schizophrenia have perceptions of reality that are strikingly different from the rest of us. They live in a world that's distorted by hallucinations and delusions. They may feel frightened, anxious, and confused. They may behave differently at different times. For instance, at times they may be distant and detached and sit rigidly, not moving for hours. While at other times they move around constantly in vigilant state or alert state. Now recently there's been some research on what are called negative and positive syndromes. We'll talk about that in a minute. First of all, I'd just like to review the classic syndromes of schizophrenia, which are on the next slide here. Hallucinations are perceptions that do not have a connection to an appropriate source. Hallucinations can be in any of the senses. They can be auditory, visual, tactile, gustatory, or olfactory. It basically means any of your senses you can have hallucinations. You can taste things that are not really in your mouth or feel things that are not really on your skin. What people generally think about are auditory hallucinations, which means hearing voices that other people do not hear. These voices may describe activities, they may carry on conversations, they may issue orders, they may warn of dangers. The second symptom of schizophrenia is delusions. Delusions are false personal beliefs that are not subject to reason or contradictory evidence and are not explained by cultural concepts. Paranoid schizophrenics, which comprise about a third of people with schizophrenia, have delusions of persecution. There are also delusions of grandeur. I had one patient who thought that he was the king of the world, except he was in like a bad time and he was actually living in a shelter, and that certain forces were preventing him from assuming his rightful place as the king of the world. Thought broadcasting is another delusion. Thought broadcasting is where you think that other people can hear your thoughts. Again, I had another client who thought that when he rode the bus in New York that the PA system in the bus was telling everyone his thoughts. Disordered thinking is another classic symptom of schizophrenia. It's the inability to sort of think straight. Thoughts may come and go rapidly. There's poor concentration. The person may be easily distracted, unable to focus. This is due to not being able to sort out relevant and irrelevant stimuli, and being unable to connect thoughts in logical sequences. Having the thought disorder leads to estrangement and isolation from other people. You know, if you can't sort of carry on a conversation that makes sense, then people don't want to converse with you. In terms of emotional expression, what you often find in people with schizophrenia is blunt or flat affect. Means they're talking in a monotonous voice, there's diminished facial expression, they look apathetic. This also leads to social withdrawal. If forced to talk, often the patient with schizophrenia will have what's called in mental health poverty of speech. It means there's just very little content coming back to them. When you ask them a question, they'll answer in 1 or 2 words. Now, I referred a minute ago to 2 syndromes, a positive and a negative syndrome. And this next slide shows how these symptoms organize into the 2 different syndromes. And I don't need to sort of walk through all these over again. You've already seen most of these or we've talked about them in the last minute. But if you just sort of glance through them, you'll get a sense of what each syndrome is about. A person with schizophrenia may inhabit one of the syndromes all the time, or may alternate between the 2. And research that's continued to develop suggests that these different syndromes respond to different medications. I would like to just point out, too, if you look down the list of symptoms in the positive syndrome, it's often what we think of when we think of someone with schizophrenia. The delusions, hallucinations, excitement, grandiosity. In my experience, working with people with mental illness and who have schizophrenia, actually I think more people evidence the negative syndrome more of the time. The blunted affect, the emotional and social withdrawal, having poor rapport with other people, having difficulty in abstract thinking. That's, in my experience, that's how I saw these patients most of the time. Now, it's always important when looking at symptoms like this to sort of keep track of what's normal and abnormal. All of us experience some uncomfortable times where we can't think straight, we're extremely anxious, we're unable to pull our thoughts together, forget what you wanted to say. This obviously doesn't mean we have schizophrenia. And at times, people who have schizophrenia don't act abnormally. Especially if they have a mild illness or their illness is controlled by medication, a person with schizophrenia can be functional. On the other hand, as I mentioned before, it's a very disabling condition, and I'd probably say most people with schizophrenia are not successful in controlling their symptoms and having a normal life. So total disability is often the consequence of schizophrenia. As Bill mentioned in the beginning, I used to work with people who are homeless with mental illness, and by far the most frequent diagnosis was schizophrenia, which doesn't reflect the prevalence of schizophrenia generally, but it does reflect the fact that if you have schizophrenia, it's really unlikely you can make your life work, and you often wind up in places like shelters. Schizophrenia is not split personality. Sometimes people confuse that, or multiple personalities. That's a different disorder. Now, I want to talk about two things in relation to schizophrenia, the role of substance abuse and violence. I think the example someone pointed out just a minute ago is an interesting point to make about substance use. Sometimes people mistake symptoms of schizophrenia for intoxication or other sequelae of substance use. There's a family I worked with that just said, if you just stop smoking pot, you'd be okay. Well, in fact, it wasn't true. He was trying to smoke pot in a futile attempt to sort of control his illness, but if you took away that drug or any other drugs, he would still have schizophrenia. Substance abuse doesn't cause schizophrenia. However, as I've suggested a couple times already, people with schizophrenia often do abuse drugs and alcohol. And this generally makes the situation worse. The medications generally available for people with schizophrenia themselves have side effects or other unpleasant aspects to it, and often people with schizophrenia do not have the awareness that they have a disorder, so they will resist taking medication and instead try to medicate themselves with street drugs or alcohol. And this generally is not a helpful situation for a person's thinking or behavior or relations with others. In terms of violence, normal society tends to fear schizophrenia, or people with schizophrenia. We feel that they're unpredictable, they have rapid mood swings, they don't perceive reality. There's clearly famous cases of people with schizophrenia. John Hinckley, who shot Ronald Reagan, David Chapman, who shot and killed John Lennon. And often when a horrendous act occurs, the first thing we think of is whether the person was insane. However, most people with schizophrenia are withdrawn and disorganized, as I suggested a minute ago about the negative syndromes. They're not energetic and violent. And there's been a number of studies that show that people with schizophrenia are no more violent than other people in society. Furthermore, when there is violence involved in a person with schizophrenia, it's often directed at him or herself rather than outward at other people. Now, certainly there is association with subtypes of disorder. People with paranoid schizophrenia probably would be more likely to harm others than themselves. But again, generally people who don't have that diagnosis, but other forms of schizophrenia, would be more likely to harm themselves. Now, what I'd like to talk about for the next couple of minutes is dealing with aggressive patients. And I've sort of likened this to schizophrenia, though I guess it contradicts what I just said, that it's not necessarily the schizophrenic who's aggressive. But there's two things that I'd like to discuss, assessing safety and then de-escalation. So I'm now on the slide that's titled Assessing Safety. And these are some tips about assessing safety, and they may be interesting to reflect back on the case we just talked about. Prior to your visit, you should always, and I should back up to say this is based on the idea of doing a home visit, although many things we're going to talk about on this slide could also apply to clinic settings. Okay. But if you're doing a home visit, you should let your supervisor know where you're going before you go. And you should also review the patient record regarding violence, either to others or to self. Also looking for psychiatric substance abuse diagnoses that might be during the charge, or head injuries. In terms of the physical environment, you should check out whatever room you enter for possible escape routes. You should look for possible weapons. You should maintain privacy, but don't get closed in to a spot that you can't get out of. You should never sit or stand in a place that blocks the patient's exit. And similarly, you shouldn't let the patient stand or sit in a way that blocks your exit. If you're doing a home visit and you see drugs or alcohol, you ask the patient not to use those, to put them away. In some cases, obviously, you just want to leave the situation. And if there's loud music playing or TV, you'd ask the patient to turn off or turn down those things. They can often interfere with your awareness of what's going on in the room at the time. In your interaction with the patient, if you're approaching a client about whom you have some concerns, keep a comfortable and non-threatening distance. It might be best to ask the patient to sit, and that you would also sit. They should speak in a calm voice. Keep your hands visible during the encounter. Now, moving to the next slide, sometimes whether you're in the home or in a clinic situation, you may be confronted with someone who is getting out of control, who's very loud or angry. So I'd like to talk a little bit about de-escalation techniques. The best way to deal with an aggressive patient is to anticipate and try to prevent problems. Before a patient is angry or aggressive, try to identify what is bothering them and see if you can help to resolve it. Some of the warning signs of escalating tension include excessive swearing, aggressive motions, increase or decrease in voice volume, nervous movements such as clenched fists or jaw tightening, and a challenging demeanor. As a second step, you have to employ active listening. Pay attention to what the patient is telling you. Don't assume you know what's happening in that situation. You should establish and maintain eye contact. You should acknowledge the patient's feelings. Patients often get upset when they think they're not being heard. So one good technique is to reflect back what the patient is saying. Say things like, "You seem very upset. I'm concerned that you might hurt yourself or others here." Things like that. Sometimes you might say things like, "I know how you must feel." Now, sometimes the patient will get annoyed by that, might say, "You don't know how I feel." But the way to use that is then to say, "Okay, then tell me how you feel." Try to turn around and use it as an opportunity for the person to tell you what's on their mind, what's bothering them. What's not a good idea is telling the patient to calm down or telling them that they have no right to be angry. Moving to the next slide. After you've listened for a bit, then you can start to talk. But the important thing is still not try to take over the conversation or dominate it, but use your talking to elicit more information from the patient who is agitated or angry. Try to use open-ended questions, because the more information you have about what they're thinking or perceiving, the better. You need to be aware of your own behavior. You need to convey calmness and control. Lower your voice. Stop and take a breath. Allow there to be silences. You should also acknowledge the patient's concerns while maintaining control of the situation. Use simple and direct statements. Encourage them to talk about their anger rather than letting their anger spill out in their actions. You can ask the patient not to use offensive expressions or language. It's not good to be drawn into arguing about the facts of the situation. In some cases, both of you may be right, But this won't help the situation. It can continue to escalate. If you become angry or aggressive, then you're giving away control of the situation. You need to remain calm and then try to get the patient to return to a more calm situation. It's not good to demand obedience or threaten the patient. And certainly you should never criticize the patient or laugh at him or her. And finally, don't offer placating responses, so like, oh, everything will be okay, or you're not the only one with this problem. Finally, through careful listening, and again, occasionally asking open-ended questions to get more information, the patient may have calmed down, and when you acknowledge their feelings and you demonstrate that you care, usually the tension decreases. So then it's the time to discuss options with them. First, you want to check back and make sure you've heard and understood the relevant details of what they're trying to tell you. You can ask questions like, in what way do you feel we can help you? Or, how would you like to see the problem resolved? So this opens the idea of there being choices or alternatives to give the patient options. What you may need to do is refer them to another service. You may need to make an appointment at another time. Attempt to meet as many of the patient's reasonable requests as you can. But it's important not to make promises you can't keep. If a patient, for instance, is annoyed about having waited in the waiting room for an hour, don't promise them, oh, I'll take you right in to see the doctor. This is an example. It's important to provide reassurance while also setting some limits. And you should be aware of the patient's body language. In the end of the conversation, you should summarize, confirm that you both agree on the facts. You can say, how does it all seem to you now? Okay, I'd like to move on to the third case study C. And as we've done with the other two, I'll read it first and then we will discuss. Mr. A is an African-American man in his 40s living in your state. He has been on DOT for 4 months. You are his outreach worker for DOT. When you're doing a home visit, Mr. A becomes very agitated. He says his apartment has been broken into and things have been rearranged. He claims that his neighbors are spying on him and that the police are no help. In fact, he suspects the police are causing things to be missing from his apartment, creating loud noises that awake him during the night, turning his landlord against him. Okay, sounds like Devlin's off mute.
It's still on. Thank you. It's just lost.
I don't know if that's someone making a comment. You want to say something about case study C?
Well, we're not. We just lost the connection. We're trying to get it back. We got it. Sorry.
All right. Okay, for those of you who are successfully still on, how would you work with Mr. A? And you might suspect with some of the things I've told you in the case study that he may have schizophrenia, may be related to some of the things he's reporting, that he seems paranoid, people are spying on him, the police are acting against him, he's agitated.
With his behavior that's being recorded in the case study, you may want to refer him for a mental status evaluation to rule out schizophrenia.
Okay. Given what you know of him, how do you think he would take that suggestion?
Probably not well. With his state of mind, already very suspicious. You might want to pull someone else into and have a professional evaluate him not without him knowing, but just have another professional observe his behavior to see if it needs to be taken to the next step.
You could also,
before you go into his apartment.
You might want to find out if how tentatively is that visit with you. You might want to say, Mr. A, are you comfortable with me being here today? You know, talk to him, make sure that he understands that you're there, you know, for him for his visit, and see if you're still right now he's still feeling comfortable with you before you initiate anything. Because obviously this isn't always the way his appearance or his affect is not always like this when you present to him every day for DOT, and now this is something new. So you want to make sure that you are safe with him. He sees you every day, but make sure he's clear with who you are and is he comfortable with you. You know, are you comfortable with me? Is it okay if I visit today? And sort of feel out, like, if he's going to be able to talk with you a little bit.
Okay, so perhaps you need to use some of the de-escalation techniques we've just been talking about.
Right.
Because he's agitated this time.
Right.
Right.
This is an outreach worker. I think they need to report immediately to the nurse case managers if they've seen a change, and maybe contact the family members if they've seen a change. And again, best reevaluate to see if this will be from any of the TB meds or anything.
Okay. Let's take just a starting point, too, that while he doesn't always act this way, he has on occasion been agitated and had what seems to be disordered thinking or paranoid thinking. Okay? So it may not be the first time. I mean, I think you were just suggesting it just seems to be the first time he's showing some of these things, then you want to figure out if something's changed. But let's say this is more an ongoing problem with this guy. He's often agitated and paranoid.
You might already have some method that you've worked out together to de-escalate him or to get him to focus on what's going on with the two of you. You as a caseworker for TB may not be able to, you certainly, unless you have some mental health background, might not be able to deal with all those other issues, but to get him to a place where you can talk to him about the TB or the medicine that day. But maybe there are techniques that you've used before, let's sit down, can we go outside, if there's something else that's worked in the past for you, if you've approached him and he's been this way.
Yeah, I think one of the points you're making is that it does say you've been working with him for 4 months. So while you may not know specific mental health techniques for working with him, there's a relationship there. You've seen each other for a while now. Even if someone's on intermittent DOT, it's a couple times a week over 4 months. They're not strangers to each other, right? You and Mr. A. But as with the other case, how do you think this person would react to your suggestion about being evaluated for schizophrenia?
Probably quite agitated. It will probably agitate him a little more.
Unless you approach it like yesterday you were doing very well, and I worry about you. I see that things are different for you today, or if you get him de-escalated, you certainly don't want to try to do that when he's in that escalated, but approach it as your concerns, and I care about you, and I want to I'd like to help you figure this out, why you're so agitated or whatever. I wouldn't mention schizophrenia. Now you're making a diagnosis, and nurses, unless you know he has a diagnosis of schizophrenia and he's on medication, maybe you already know that since hopefully you have listed out his meds. But, or maybe, you could say, have you talked to so-and-so, your mental health caseworker, or your therapist, or your, liaison, your social worker. When's your next appointment with so-and-so? Maybe bring that in so that he knows that you're thinking about that.
Okay. Well, again, he may not be connected at all with mental health services. And that's maybe the challenge here. The second question here, would you go into his apartment?
Yes.
that's when you might say, if you came in and saw him like that, you might say, could we step, would you be able to come out with me and sit out here on the, out on the bench, or are you able to come out of your apartment? Can we have our visit outside? Depending on where it is, obviously confidentiality, but maybe get him away from an environment that's making him upset. You never know if he is schizophrenic, what's going on for him there, what kind of issues are going on for him in the apartment.
Okay.
If I sensed I had a rapport with him, I think I would probably go into the apartment.
But I hope you'll think about the assessing safety list I gave you, right, about what things to look for and be aware of when you go into his apartment. In terms of exits and weapons and other things. Okay. We have a little mute for a little there. One other comment, I think an area to find out which work is differently. Some areas they are not nurses, so I would think that this needs to be reported to this case manager for home assessment. Okay. Again, given the scenario that maybe someone's not connected with mental health, the client is not, Mr. A is not connected with mental health services, and you're seeing a clear need for someone to take a look at him, how do you think you might get him in the door of a mental health clinic or psych clinic?
You might take somebody with you the next time that you go, and maybe somebody. I work for the county health department. Maybe I take somebody from mental health with me, liaison with them, and see if they would be willing to come in and talk with him. Let him know that I have some concerns and I brought so and so with me, to let him know about what's available.
Okay.
Just offer it out.
That's a good thought. You don't have to try to get him in the door somewhere, an appointment, rather bringing somebody with you. Good point. Are there ideas about how you might approach this with him?
You could just tell him you wanted to come back in for a TV evaluation, and that way when you get him in, the physician could evaluate that. In case he's resistant to being evaluated for mental health problems.
Yeah, I think that could work. I guess I work in a setting where the mental health people are it's physically a different place than the chest services, and it might be hard to engineer that.
I think you have to be, continue to be trustworthy with this type of patient. I mean, I think they're an adult and you are an adult, and obviously, they may be going through something, they're escalated in their illness or whatever, and but you still have to be honest with them and let them know that, because then they're never going to trust you.
And also, I believe that they have to be inclusive.
Yeah, you just use the input. I think that's important. Take them in the clinic for one purpose, but really to have them looked at by somebody else. He may feel he's being ambushed.
And if he already has issues of, feels like people are talking about him or whatever, he may not be comfortable with that. Now you've lost him. You were the precipitating issue for that, and he may not. All the work you've done to get him to be compliant is out the window anyway.
Okay. One suggestion I might make is, say if this person's not connected with mental health services and you think they need to be, or at least assessed, I think, again, you have a relationship and try to figure out, sort of what's working about that. It doesn't seem from the case study that he's blaming you for everything. He's blaming a lot of people for a lot of things, but not you. So you seem to be an ally. It sort of provides an opportunity to make a gentle suggestion, to have someone else come in to talk to him or to take him to another clinic that he hasn't been to before. In my experience, what that sometimes takes is a little sort of bargaining, like, I've helped you with that, but I'd really like you to do this for me. Or even sometimes to sort of say, you know, for me to continue working with you, I need you to do this. And obviously, if someone has active disease, you can't sort of say, do this or I'm going to drop you, because you're not going to drop them. That would be a lie. But to try to use a little bargaining. I mean, that's what we've seen in some of our cases with patients who are denying their mental health problems. So like a little bargain, I'll help you with this, but I need you to do this for me.
And if you use incentive, not to bribe, but to enhance the treatment, if you're given incentives of food or whatever, or a bus ride or whatever, you can say, you know, I really worry about you. You know, we can certainly deal with getting you food and such, but this is another incentive, or you know, I want to help you in another way, or something like that. Or I worry about you. You know, I'm giving you a bus ride tomorrow to ask for that for some tokens. I'm worried what will happen to you on the bus. You know, maybe, you know, something awful could happen to you. You're feeling this way, paranoid or whatever.
The final question here, how do you think miscellaneous behavior affects his adherence? Well, I guess many of us feel that if he's erratic, paranoid, it may be difficult to maintain a relationship with this person and continue to help him be adherent. That would be the challenge in this case.
Well, I also think he's going to, I've not known anyone where they would stay at a level like that. I mean, there's going to be an escalation or some concern about his life becoming more chaotic, and that would make it next to impossible to continue treatment. I mean, it's done, but it's challenging. It's going to make it very difficult for us to adhere if it's not safe to enter his premises, or if we're fearful of our ability to carry out DOT.
And I know there has been some people been incarcerated for refusing to be adherent when they have active disease. And I mean, some of that could come from mental disorders, people refusing to acknowledge that they have tuberculosis and then refusing to take medications. Okay, I think unless anyone has questions about schizophrenia or these specific techniques about assessing safety or de-escalation, we'll move on to the final slide here. Any questions? Okay. In summary, it's good to know who's available to help you when you might come across any of these sort of problems that are presented by these case studies. Now, do you have a psychiatrist, a social worker available? Is there a psychiatric emergency room at your facility? Some of you are based in hospitals. Another thing to think about is, what information should you have at the start of working with a client about psychiatric issues? So often, we don't know much about people when they first start treatment with us. Another question is, to what extent can you get more information? The client on whom that last case study was developed, when we first started working with him, we didn't know of his diagnosis of paranoid schizophrenia. But later in time, as he is in treatment and we were able to view his hospital chart, then we saw that. Now, we had already built a relationship with him and already worked with him for several months before seeing the diagnosis. So in a way, the diagnosis, it's not like you need to have a diagnosis to know how to interact with someone. You're seeing what you're seeing. And as I suggested at the very beginning, you may have someone who has schizophrenia, paranoid or not, who has not been formally diagnosed yet. So it's not always that you can have a history or a chart to refer to. The thing to think about when referring patients to mental health services include the items listed on the slide here, the impact on TB adherence, your safety, danger to themselves or to others, and your relationship with the patient. And I think in each of these case studies, we've talked about that as being either a factor that could help you move the patient to another place, not necessarily physically move them, but emotionally, or get them to accept an idea of a referral to mental health services. Well, I think in the second case study, we acknowledged that there wasn't a relationship. This was a contract investigation situation, so that made it different than somebody you've worked with for 4 months or a year. I think at this point, I'm finished with my presentation. If there's any general questions or comments you'd like to make, I would welcome them.
Any questions or comments, please?
Thank you for offering the seminar, and it was good information and helpful to talk with other people out there treating TB patients.
We could, go over the identification of psychiatric disorders as well. It's been a while since I've thought through them and seen the list, and that was helpful.
There's, of course, other things I could have talked about, but in the interest of time, I chose to pick, most common mental health issues you might have to deal with, such as depression and suicide. But then also, again, the point of schizophrenia is not so much that you will encounter a lot of people with schizophrenia, but rather it poses special challenges.
Thank you very much. That is all the time that we've allotted for the WebEx seminar today. Thanks a lot, Paul, for sharing your knowledge and experience with all of us. And thank you to all the participants. Your questions and input and discussions made it really lively today. Thanks. If you do have additional questions, you should feel free to email them to us, and we will be happy to address them. I would also like to remind you of 2 upcoming WebEx seminars. On June 26th, from 1 to 2:30 Eastern Standard Time, this will be a nationally available seminar on quantiferon. The speakers will be Drs. Alfred Lazizaro from the Northeastern Regional Training and Medical Consultation Consortium, Masai Kawamura from the Francis J. Curry National Tuberculosis Center, and Philip Lebu from the Centers for Disease Control. This will be sponsored by the manufacturer Celestis. And in early fall, in September, there will be a WebEx seminar on risk communication, which will deal with the issues of communicating with management and staff at a sort of a place, a congregate setting or a workplace where there may have been people exposed to an infectious case of tuberculosis. In addition, there are several other course offerings for in-person courses or other courses available that are listed on the website of the New Jersey Medical School Global Tuberculosis Institute. Again, that's www.umdnj.edu/globaltb. At this time, I would like to remind all participants to return the evaluation forms, sign-in sheets, and continuing education information sheets to the address or fax that's noted on each form. A recording of today's program will be posted on our website along with related conference materials. And finally, note that there are several resources related to this topic available from both of the centers that sponsored today's WebEx seminar. This concludes the conference. Thanks very much for your participation. Bye.
Thanks for using WebEx. Please visit our website at www.webex.com.